And I'm going to start recording now so I don't forget. And then I'll put the Zoom recording online later. So it does take it about a half hour to process. Anybody have questions at this point? Mrs. Reardon is coming in. Once she gets an exam completed, she knows we're on here till 3, and she'll answer all your questions about ATI. What I can tell you in the interim, ATI is in 2 sections. One section is the leadership assignment in ATI and the comp predictor test, which you take during class. ATI that's virtual is a whole different thing, and that will not open for another week or 2, and that's not due to the end of the term. So you have time to get virtual ATI assignments done, and she'll go into more detail for you when she comes online with us. Any other questions at this time? Mrs. Reardon will go through ATI with you then. I'm just double checking everybody's here. I think I'm still missing one person. But yeah, let me get into Mr. Leave's content so we don't get too far behind, at least with the med surg critical care stuff. Can everybody see? Make sure I'm sharing. Can everybody see a PowerPoint slide that says respiratory case study?
Yep.
Good.
Yes. Yes.
Very good. This one's a little long. This is about 60 slides, but the bulk of this is about a respiratory patient, and it gets into ABGs. And then after this PowerPoint, we'll get into some of the broad concepts of mechanical ventilation. Fortunately, with Harrisburg campus does not get into the particular modes of ventilation as those other campuses do. So that's a good thing in a way, because really, unless you work in critical care, you're never going to have to know modes of ventilation. And they're a little difficult to learn at first, but as you work with vents, they're not that difficult. I think other things with critical care is hard to grasp. As far as vents, the modes are the worst thing, I think, to learn. So going through a case study, and this is how Mr. Lee normally drives his lectures, is through presenting case studies. So we have a gentleman that's 50 years old, so he's middle age, African-American, coming to an ED where we're working, and he's complaining of having shortness of breath for 2 hours. He has a long history of emphysema, so it's COPD. He's using home oxygen at 2 liters a minute by cannula. So our concept, and HACC has been driving its curriculum now for the past several years through concepts, broad concepts. And this one is oxygenation. So what will we want to assess with this particular gentleman that we know has COPD, emphysema? He's coming to us for help because he's very short of breath. He is on oxygen. And it looks like that's a proper dose of 2 liters. What should we do as far as nurse level? And we are RN students, so what could you do as an RN as far as assessment? Does anybody have any insight?
His lungs.
O2 sat, assess lungs. What else can you do for him? What other interventions can you do?
Raise the head of the bed so he's sitting up straight.
Absolutely. And if he has to, you can always put the bedside table over and do the tripoding. Sometimes that helps them. I know for having working palliative care, that helped with those that were end-stage emphysema, COPD. Just using furniture like a bedside table or a table to help them in a position that helped them breathe. What more information do we need about him?
What medications maybe he's on?
Medication. If there's additional medical information we need to know about, maybe that one person. I had one other person leave in there, sorry. Medication, his other history, what's been happening to him the past 24 hours? Does he have an infection? Does he smoke? With the assessment of oxygen, we want to look at accessory muscle use. We look for chest contractions, how they're positioned. We're looking at the chest rise and fall. The videos are helpful. And for the sake of time, I'm going to let you go back and look at those as you review the PowerPoint. And what I'll do, because you have the student version, what I'm showing you now is like the instructor version where it has a lot of answers. So I'll post that later so you can go back in, you can see the answers, particularly to the ABG studies we're going to look at. And then you can play the video links. I think you as LPNs should have an understanding of a lot of these basic assessments and interventions that I'm going to have video links for. So what it does, it just reinforces the review of information. Because we're dealing with oxygenation, we do want to know how their ability is to speak. Are they able to speak clearly? Does it take a lot of effort? I'm just leaving 2 more students into the classroom. What's their mental status? Are they coherent? Are they confused? Are they going unconscious? Because oxygenation is going to affect their mentality. Lung sounds, as a student mentioned, this is very critical. We really have to listen to all lung sounds. Now, I'm not saying all 22 lung fields that you're usually taught in nursing school, but you definitely want to hit the upper, superior lobes, the posterior, the bases, both in the front and the back. Listen to the sides of the lungs because we know fluid can establish itself to the side, lower and midsections of the lung field. So it's very important to do a very thorough lung assessment. And vital signs, we absolutely have to have vital signs because as we give medication or start doing more, if we have to do more invasive interventions, if this patient would have to go into vent, we really need to know base vital signs because that's going to drive then the care that's rendered if he becomes a very critical patient. Skin color. Skin color gives us significant amount of information as far as oxygenation. So that's also a key piece of information to know. And then nail beds. Are they blue? Are they pale? Are they rounded? They're starting to spoon. That's also important. And the nail bed skin color assessment can be a challenge if it's someone of the different skin color, even if they're heavily tanned or if they have conditions where their skin color could be altered. Because my 150s student, the PENR 150 students learned yesterday that diabetes over time can darken the skin. So you have these areas of like grayish black shades, and that can really throw you off as far as assessment. So doing a thorough assessment is very important. So here's our assessment for Mr. Phillips. He's hypertensive, heart rate's elevated, respiratory rates very high. He's using his accessory muscles, so he's struggling to breathe. There's his temp, speaks short sentences, skin's moist with some gray coloration, so he's not getting oxygenated. He's a little sleepy, but he's still oriented, so he's getting exhausted from the work of breathing. And I can tell you, with my wife having severe COVID, which she avoided having respiratory issues, but she ended up having cardiac issues. She says being short of breath, being deoxygenated is extremely fatiguing. So we know, as the student pointed out, by assessment of lungs, which we need to do, there's coarse crackles in all lung fields. So we know there's fine crackles, but coarse crackles is worse because there's this indication of more fluid accumulation. And at this point, do you feel he is experiencing mild, moderate, or severe alterations in his oxygenation?
I would say severe.
He definitely is.
He
He's
is
getting to
severe.
the point where we're going to have to do some invasive interventions to keep him stable. So early signs of respiratory distress is the restlessness, irritability. They're tired. Their body's going to start doing things to try to compensate. And when the body tries to compensate, it usually doesn't do it very well, as you're going to learn. So He has mild tachycardia, headache. Headache is common with a lot of problems, even with diabetes and stroke. So that's why assessment is so key with anyone that's in an emergent situation. You really have to look at everything because a lot of things, a lot of different conditions, the symptoms are very similar, if not the same. There's respiratory distress, the tachypnea, the nasal flaring, the nostrils open up wider to get more oxygen in. The accessory muscles are trying to breathe in more air. There's peripheral cyanosis, so we're seeing early signs of deoxygenation. The late signs are confusion and stupor, lethargy, definitely tachycardia. The arrhythmias begin. Once it depends on their heart disease, their heart condition, they can go into bradycardia. There's central cyanosis, so the deoxygenation is so severe that now their central trunk is becoming altered as far as ability to maintain normal color. There's diaphoresis, and then once the patient is depleted of minimally required oxygenation, then they go into respiratory arrest. So Mr. Phillips, he's with you in your ED. What do you want to do for him at this time? What would be our priority set of nursing interventions?
Some type of intervention to help him oxygenate better. So like a BiPAP or.
Right. Mm-hmm.
Have them in high Fowler's position.
Yep. Mm-hmm.
What about also treating him for maybe anxiety, because being that he's having problems breathing, he might have anxiety issues, and that could cause breathing issues as well.
Right. We can increase. Depends. You have to be careful with oxygenation because these emphysema. I know that sometimes you do have to add a short term. You may have to use both a mask and a cannula to just get air into these people, because as you're going to see, they're getting 100% oxygen, but some of it is going to where it needs to, and some of it is going somewhere where it's not being used. And that goes into ARDS, which is what you'll be reviewing by podcast. And I'm going to demonstrate that later. And I have I've created a handout for you that's on D2L that you can download and print out that will help with all this today. So we can reassure, help him rest as best he can. That'll help decrease anxiety. Again, continue to elevate, as you've been pointing out. It's a good idea to collect a finger stick blood glucose because he could be diabetic also. As you probably figured out by now, as I try to teach my lower level students, patients don't come to us with just one problem. They have multiple, and they are like cats. They mimic, they cover up, they cloak a lot of problems. So our patients will have multiple system issues, and it's sometimes difficult to see exactly which one's being the main issue. So this guy could be diabetic as well as have heart disease. So we're probably seeing multiple system issues at the same time. We want to prepare and initiate and titrate oxygen. And that's a challenge because he's emphysemic. We should have suction available if we need it. At this point, as he's deteriorating, we want to notify rapid response, and that we will do based on the protocols of your facility. I know some ICUs handle their own codes. Some ERs, EDs handle their own codes and emergent situations because they are the emergency department, but some may be a small hospital that we have many in our region. They may call for a rapid response situation. We have multiple responders come. So additional help from critical care nurses come, respiratory therapy comes if they're not already there, and usually a physician responds. So which would be your priority?
The focus assessment of the lungs and the heart.
Absolutely. Mm.
Would you pull ABGs for this patient too?
Oh, yeah, that's where we're going. You
Okay.
got it. You got it really well. So you guys, this isn't bad. You guys know what you're doing. I'm not worried. It's this ATI that's screwed up. And a couple things on the syllabus that I'll get tightened up for you. I'm gonna let you look at this on your own. I've drawn ABGs before. It's a skill that's, I think, harder than starting an IV for somebody, because you really have to hit this artery that's in the wrist first time, and it is extremely painful. It burns, so it does take some practice to do this right. And I'll let you look at that on your own. Usually RT, respiratory therapists usually do this, but if you work in critical care ER, you could be doing your own ABGs. Just to review, and as we go through the sample questions of ABGs, we're dealing with pH, saturation, partial saturation of oxygen and CO2 in the blood, as well as bicarb and O2 set. So these are the ABGs that we are drawing for Mr. Phillips. And what would be your assessment? And again, you can pull out from D2L, and it should be there for you. In the things to know section for week 1, at the bottom, you'll see a PDF document. It will talk about ABGs. That handout's good to print out or look at as we go through ABGs. So help you do this. So
Uncompensated respiratory acidosis.
So you're doing a respiratory assessment?
yeah, he's definitely respiratory, and he's definitely acidosis. He's partially compensated though. And you'll see this again as we go through the examples. So I have like sample questions with ABGs we're going to go through soon. He's very hypoxic, so he's in a hypoxemia situation. With the acid-base situation, there's an imbalance going on. So there's acidemia, there's alkalemia. So basically, if someone's pH level in regards to their ABGs is less than 7.35, they're considered in an acidemic or acidic situation. If their pH is greater than 7.5, then they're in alkalemia or they're alkaline. They're more stable as far as pH is concerned. The problem with the acid-base balance is that if it's not balanced correctly, it's going to be detrimental to the kidneys. And we know the kidneys is the source of our blood pressure. This diagram, what it's doing is comparing arterial versus venous as far as blood gases. And we use arterial for the best way to intervene with changes in our patient's stability. And so you can see with these guidelines, with the parameters, where patients should be when we draw ABGs on them. With the pH specifically, we're always trying to keep the patient somewhere between being acidotic and alkalosis state, so somewhere in between the two extremes. Our bodies are always somewhere in the middle, maybe a little acidic or a little alkalinic, but for optimal function, our body should always be somewhere between 7.35 and 7.45. As far as CO2 in the blood, in arterial blood, somewhere between 45 and 35. And the bicarb should be somewhere between 22 and 26. So the dividing line when interpreting ABGs with regard to pH is how acidic are they or how alkalotic are they? The compensation, this is where the body's trying to do something to correct the pH of the blood. And sometimes it's effective. In the case of our patient, it's partially successful. If compensation is not doing what it needs to do, then it's absent, and we consider that uncompensated. For Mr. Phillip, his body at this point is doing a partial job, maybe 50% or so of compensating for his acidic situation, so we call it partial. If all his ABGs are normal, then we have full compensation and they would be fine, but he would not have all the symptoms that we're assessing. And it is the respiratory system that is the most sensitive to pH, and the body's going to react within seconds to respond as far as compensating. If it's healthy, if there's other issues going on, then the response won't be as fast. The renal compensations are more powerful than respiratory, but are not fully triggered unless the compensation imbalance continues for many hours. So the kidneys are effective, but they're not as fast as the respiratory system. And again, we're basing now on the fact that the kidneys and lungs are healthy. And in our patient, that's not the case. So how does the body compensate with regards to ABGs? The lungs or respiratory system compensates from metabolic disturbances by changing the carbon dioxide excretion. We're either increasing or decreasing our respiratory rate and volume. And in critical care, you'll see that with how the nurses, and mainly respiratory therapy, will adjust the vent and using the different modes of ventilation to do the same thing, and may do additional things such as medication. But I leave that to your clinical and then orientation to really get the nitty-gritty with how vents work, particularly the modes or the different ways that the vent can work to help with respiratory rate, volume, PEEP, and so forth. The kidneys are metabolic, so they compensate for respiratory disturbances by altering the bicarb retention, synthesis, and hydrogen excretion by the urine. And the bottom calculation is helpful. Nothing you need to know for this course, but it may help some to further understand this compensation capability. But just remember that the lungs, which are respiratory, compensate for metabolic disturbances. The kidneys, which are metabolic, compensate for respiratory disturbances. They kind of complement each other. The lungs are faster in response to compensation. The kidneys are very effective in compensating, but they're slower. So here's some questions. Mr. Lieb set up a tic-tac-toe game to have you practice ABG interpretation. I think it's a little complicated, but it's worked for other groups of students, so we'll go through this. This is an uncompensated set of ABGs. So what's happening here? Is it metabolic or respiratory?
Metabolic.
Is it, and where would we put the X's? I'm using circles, as you'll see in the next slides, the answer. Where would the X's or dots go as far as the tic-tac-toe goes?
Under the alkalosis, metabolic alkalosis.
Mm-hmm.
I guess I'm confused about like how it's set up.
Yeah, let me just.
pH goes to alkalosis.
Yeah, because I think with Zoom, this is hard. This is hard to do with Zoom because if we were in a classroom, we could do it on paper, and I think it'd make it a lot easier. But by Zoom, this is kind of hard. So it's uncompensated metabolic acidosis. So the pH is high. So there's alkalosis going on. The CO2 is 40. So it's basically normal. So it's in the middle. But the bicarb is high. And when you go through my handout, which is on D2L under week 1, there's a blue chart there with arrows, and it will help you understand how do these three things, as far as pH, PCO2, and bicarb, how do they need to be to create or determine the compensation, whether it's metabolic or respiratory, and if it's acidic or alkalosis. This presentation, I wouldn't use this, but Mr. Lee asked me to. The main thing here is this to understand for uncompensated metabolic acidosis, the pH is high, the CO2 is normal, and the bicarb is high. And again, going D2L under week 1, under the subsection, what you need to know at the very bottom is a handout. It should be a Word document, and it'll come up as a blue chart, and that gives you all the different sets of ABGs. There's little tiny arrows that tells you how the pH, CO2, and bicarb need to be compensated, uncompensated, metabolic, respiratory, acidosis, or alkalosis. If this is something that's new or still difficult to know, just keep reviewing it. I have to, because I don't use it all the time. Really, after some review, it's not that bad. Partially compensated ABGs, this particular set of ABGs, this is partially compensated metabolic acidosis. Everything is low. The pH is low, the CO2 is low, the bicarb's low. Then it's partially compensated metabolic acidosis. ABGs, again, if this is a challenge for you, I always have to look at it. Go through it a couple times with PowerPoint. My handout particularly gives you the guidelines to figure this out. You'll get it. It's just something you have to review. It's just like learning EKGs, particularly blocks. It's this, if the pH is high or low, if the CO2 is high, low, normal, same with the bicarb, determines the different criteria, whether it's partial, full, metabolic, respiratory, acidosis, or alkalosis. To be this particular set of ABGs, the pH is normal, but the CO2 and bicarb are high. That is fully compensated respiratory acidosis. And again, what I'm going to do is I'm going to put this PowerPoint on D2L so you guys can go back through and practice these and see my answers. And then this particular one, this one's a challenge because someone can be compensated respiratory alkalosis and metabolic acidosis at the same time. So that's why there's two sets of dots in the tic-tac-toe game. So if you look at my blue chart, you're going to have the criteria all the same. So if the pH is normal, the CO2 is low, it's acid, and the bicarb is low. Both are the same. Just keep reviewing ABGs, you'll get it. It's just like EKGs. It's just something you just have to take some time to go through to get it. once I'm done with this, I'll point out, I'll share screen the handout for you.
You go over like the compensated and uncompensated again, what makes it one or the other?
Yeah, let me go back here. So compensation.
I understand for the respiratory, but I
okay.
think renal is what's confusing me.
Yeah, the problem with renal is the lungs are the fastest to respond. So the kidneys are slower to react to the situation where something needs to be compensated. So that's where the partial comes into play.
So with like metabolic or with the kidneys, will you see the compensation within the respiratory ABGs? Is that what you mean?
Yeah. Mm-hmm.
Okay.
Yeah, because they
Alright.
complement each other.
Okay, that makes sense.
The lungs do metabolic, kidneys do respiratory.
Okay, got it. Thank you.
Keep it basic. We are keeping it basic. Now, if you get hired in critical care and do the god awful critical care courses for UPMC, WellSpan, you'll get more than you want to know.
Where did you find that handout you were talking about?
Oh, let me show you. Let me get out of this a minute. I see Mrs. LaRue has joined us. Sorry to ignore you. Did you want to get into ATI stuff?
If you would like me to.
Let me ask the class, because we just finished ABGs, and I think it's really confusing for them. They need to really review it.
Okay. So you want to take a break and talk about virtual ATI? Oh, I know. It's so good to see so many of you. Look at you. You're 251ers. Yay! All right. Something that that your course fees have paid for during your time here in the RN program has been this wonderful ATI product, or at least faculty think that it's wonderful. You guys might be going like, oh my gosh, no, not another thing. But what the virtual campus is a way to get you started, to get you ready. I want to tilt my camera down here just a little bit. Let's see. To get you ready to sit for the RN NCLEX. Now, because all of you guys have already gone through this with you're all licensed LPNs, you do have sort of a good feel for what that type of testing is about. And what our dedication is to you is to put you in the best position possible to pass the RN NCLEX first time around. Nobody wants to do, I call it the walk of shame, where you were unsuccessful on NCLEX, and let's say maybe you've gotten a temporary practice permit, you're on orientation, you've accepted a job, you know, life is good, you're getting the bucks, and then all of a sudden you're not successful on NCLEX, and your facility comes to you. I have actually heard facilities are saying, well, we're terribly sorry, but you know, you're this contingency job offer we gave you based on you passing NCLEX is now no longer, you don't have a job with us. Or they might ask you to step back and assume the role of an aide. Now, you guys have got your LPN licenses, so, you know, again, this is going to be a little bit different if you're, you know, if you're looking at the temporary practice permit route. We don't recommend it. We'd much rather have you have your license. You're much more valuable on the marketplace with your license. So just got to keep your heads in the game here and you know, go through some of these programs. It is a tried and true system. Our RN NCLEX pass rates are greater than 90%, which is fantastic. So, you know, we've got a good system in place for you. So what the virtual campus is, you will be getting that Mr. Klein is going to be sending in some information on you. I'll be here to assist him to ATI. So first step is I need you to go onto your ATI accounts, and under your account settings, we need you to make sure that you're using your Hotmail account. Don't use a Gmail account or a Yahoo account. It needs to be your HACC email account, because everything that we've done with you over the course of this program has been based on your H numbers and your HACC email addresses. So that's step number one. So please do that quickly. And then what we'll do is we're going to send all that information to ATI. And about, I think it's, I need to get an exact date, but here's what I want you guys to write down. In and around, I think it's going to be around September 17th, which is a Friday. Between Friday, September 17th and Monday, September 20th, you will be getting an email to your HACC email address from your ATI virtual coach. Now, the ATI virtual campus is in its full form 12 modules. You are only going to be required to complete the first 5 modules. And then I'm here to tell you that module 1 and module 2 are really, really easy. And they're going to be modules that tell you how to interact with your virtual course, how to set up a study, timeline to get yourselves ready for NCLEX, how to navigate the virtual campus. So that's modules 1 and modules 2. Modules 3 are going to take you back into the realm of fundamentals. This is not like taking the fundamentals proctor exam that you possibly took, somewhere in your experience. But you have to work through this. You're going to be working one-on-one with your coach. And your coaches are all at least MSN trained nurse educators. So these aren't fly-by-night people. They're going to be looking at diagnostics. And here's the mantra for this. I know some of you heard me say this in 241 this summer. You need to trust what you know and focus in on those areas where you're not as confident. And that's what the virtual campus is going to do for you. So they're going to identify those areas in fundamental nursing, module 3, in pharmacology, which is module number 4, and then in medical surgical nursing, which is module number 5. And they're going to look at those areas where you're weaker. And then they're going to give you remediation to do. And then you do it, and then they call it green lighting. They're going to say, you know what? Yay, you finish that module, move on to the next. And what Mr. Klein will get is a weekly report on your progress. We keep up with you as instructors to make sure that you're interacting with your virtual coach on a weekly basis. You'll also get messages from your virtual coach if you haven't submitted anything. They'll send you a little message and they'll say, oh, you know what, Karen, we haven't heard from you this week. Are you, is there a problem? Is there anything that we can help you with? This is timed. They have it laid out for, a number of weeks before you go into your final. So we need to make sure that you stay on track with this program, okay? That's why we kind of start off with the fun, ugly med-surg stuff of this, because then you'll go to Mrs. Reardon and it's leadership and management. That's fun. You'll have a good time there. But sort of the new stuff that you're learning right now, we like to kind of get through it before you move into the virtual campus setting so that you can just really concentrate on that. Now, the other thing that you need to have an awareness of, modules 3, 4, and 5 have got points associated with them. So you complete those modules, you'll get those points. You need to get this done before, we'd like you to have it done before the end of your 251 course, but we do give you until the end of the college testing period for the mini. Ooh, you know what? I'm misspeaking, Noel. I'm so used to doing this at the end of the second mini semester. So Mr. Klein's going to give you a date, usually right before when grades are due, when we have to enter our grades in on you. And that's probably when this is going to be due. Is that correct, Mr. Klein? And we can talk about that.
Yeah, because my students, they've been looking way ahead, and because the shell they're using now for fall was the spring shell. So Mrs. Reardon, Mr. Lee copied all that over, but because Mr. Lee's absence, a lot of the nitty-gritty dates weren't catched. So there's a lot of things that need updated.
Okay.
And one
You
thing,
know,
the modules, getting a lot of questions from students as far as what do they need to do for virtual, what do they need to do for regular ATI, and what needs handed in to Dropbox.
okay, so you're going to probably have 2 assignments. You're going to have your comprehensive predictor assignment, and that's where we're going to ask you to go into ATI, into the comprehensive predictor practice assessment B, and to do that and to do a remediation on that. Then you'll take the comp predictor proctored exam. Now that one's a kick in the butt, guys. I'm not gonna lie to you on that one. When I gave it this past spring, and I usually don't like to talk in terms of how many questions, but that was up to 160 questions. You have probably not sat and done 160 questions. Okay, so this is, again, this is to get you ready to be able to sit to take NCLEX. And the comprehensive predictor is really important. It's going to give you a probability score. It's going to give you a raw score, which tells you basically how many questions you got right out of how many questions you got wrong. And when you see that first score, you're going to go, oh my gosh, there's no hope for me. I'll probably never become an RN. Don't look at that. That raw score translates over onto a table that then tells you your probability of success on NCLEX. And it's that probability score that we will assign points to you. So I'll be working with Mr. Klein. Mrs. Reardon's going to be working with Mr. Klein. We are so sorry that, that we are really sorry Mr. Lieb is not with us right now. We're so thankful that Mr. Klein is, but we'll get these dates worked out for you. All right. So that'll be towards the end of 251. And then, like I said, probably around September 17th, that's when the virtual ATI will kick in. And again, you'll be able to get through those first 2 modules really quickly. And then when you start module 3, which is the fundamentals, they're going to have a little diagnostic test that you're going to take right straight up front. Again, trust what you know, and where we're going to study is in those areas where we're not quite as good. So what that diagnostic test is going to identify are those areas where you're not as strong. And then your virtual coach is going to have some, remediation for you to do. So it's really important when you go into the virtual campus and you take that diagnostic test, take it seriously. You want to do a good score. That's going to decrease the amount of remediation that you have to do. And then once you get your remediation done, then your virtual coach says, you're good to move on to the next module. Next module, pharmacology. You'll take a diagnostic, just like you did with the fundamentals. Do your best, take it seriously, because that'll cut down on the amount of remediation that you're going to do. So the virtual campus, they like you to do basically one module a week, knowing that you can get those first 2 modules done pretty quickly. So we want you to have those done by the point in time that we have to enter grades for the first mini-mester. Now, if you don't get them done, all right, things happen, don't they? If you don't get them done, we've got points that are associated with these virtual modules for modules 3, 4, and 5. Wherever you are when that, endpoint comes, when we have to turn in grades, you will get an incomplete. You're still going to be required to finish the modules to remove the incomplete. But then whatever points you've got outstanding from those modules, you will not be able to get those points. Your points will end at that time when the grades are due. Is that kind of clear as mud?
All very.
Okay,
And
so
just, because I'm getting a lot of questions through Messenger.
Okay,
That here, let's say the right thing. The comprehensive practice assessment's open, but not the leadership practice.
and you know what? What I would probably do, whoops, I just lost everybody here. Just a second.
Okay.
You guys kind of know how good I am on the, there we go. You're back again. Let's wait and let Mrs. Reardon address that, since you'll be with her for leadership and management.
Actually, they have me for all that. I'm doing Mr. Lee and her content. At the school.
Oh,
Everything those two do on 2 separate days, I do in one.
so you do in one day.
Yes.
Oh my gosh,
So you
are
can
you
imagine
like awesome?
where
So
we're at
yes.
today. So
So yes, for leadership and management, you will get points for that. So it's probably taking the, at least at minimum, practice assessment B, doing remediation, and then turning in some, remediation forms.
It says
Notes.
A for us.
It says
practice
A.
A. Yeah.
But it's
It
not
does-
open. I don't have it on my ATI screen. All I have is the comprehensive one.
All righty. So let's make sure that we get leadership and management open for you guys. And you're the 1021 stack cohort. Oh boy, don't I know that one. I'll make sure that the practice assessment A and B are open to you. I recommend practice assessment B because it gives you more exposure to those alternative questions, which are predominantly the harder questions that you'll be exposed to on NCLEX. So, but I'll make sure that both of those are open.
And we can pick any 2 templates we want to do for remediation.
Yes. Mhm.
Okay.
And we could do A or B then?
You know what? Let us get back to you on that one. And let me meet with Mr. Klein, and we'll make sure that we have a coordinated front that we bring to you on that.
So my understanding is, back to the virtual one.
Yep.
We must complete all the modules, no matter what.
Mhm.
We have an extension, it says in there like 6 weeks after, but whatever we don't have done by
Mhm.
finals, we get a 0 for those particular ones that you don't complete.
That's exactly right. You won't get any points, any additional points.
Okay.
And the grade that will be entered for 251 will be an incomplete until you finish those modules. And let me just, I want to take just a moment right now. I know you guys have gone through this before with your PN program, but it's the same sort of thing with the RN program. We need to submit your nursing education verification form, that NEV form, to the State Board of Nursing. If you get an incomplete, that's going to kind of jam you up with the submission of your NEV to the State Board of Nursing. So we really, and I'll kind of give them, the mommy talk to Mr. Klein, that we're going to ride your butts pretty hard to make sure that you get those modules done so that you don't get caught in this situation where you're going to get an incomplete. Okay, we want to make sure that you get all of the points and that your grade, that you finish this course on time. Now, again, things happen. And when things start to happen, what you need to do, you need to be very proactive for yourselves. You need to reach out and you need to let Mr. Klein know. Please communicate. That way, we can give you suggestions and, things to do. Much rather hear from you sooner than later. All right.
Can we?
And please trust me on this. You've got the same amount of time, 6 weeks, that, all of the, my course right now has, where I'm in 250, but in the second mini master with 251, you can do this. You can do it. You can get it done. Okay.
How do you
I've had
initiate that
students-
email
Huh?
how do you initiate the email to the virtual coach? I mean,
The
you make
virtual
sure.
coach is gonna email you. You will not, they will email you, they'll introduce themselves to you. And that's why it's important on your ATI account that you have your HACC email set up. Don't use a Yahoo or a Gmail account, because then they're not going to have any way to get in touch with you.
Dr. LaRue, so with the ATI setting up the email with a HACC email, we don't have to change our account login, right? You just have to add in like the HACC mail email address, right?
That's exactly right. That's exactly right.
All right, thank you.
Okay.
I guess what I'm asking is how do they know? I guess they on the 17th to the 20th, they just go and see who's in our
What
class.
ATI will do, we're going to provide them with your class roster, your names and your email addresses. ATI is then going to assign you to one of their coaches. So then the coach is then going to get in touch with you via your HACC email account. And that's where again, and there will be probably a few of you, somewhere between September 17th and 20th, you're going to go, I didn't get my email. Everybody else in the class got their email. I didn't get an email. And the reason probably is because they didn't reset their ATI email account to their Hotmail account. So your virtual coach, they'll introduce themselves. They'll welcome you to the program. Right around this time, Mr. Klein will show you a couple of information videos that ATI gives us that explains the program. And so you'll do that in class. And I think you'll feel very comfortable with it. This is something, it's new, it's different, it's at the end, and everybody's nerves are, pretty well fried at this point, but please trust me, it's very doable. And it's very worthwhile. So here we've got, and like I said, in terms of some of these drop boxes and completion dates, please do extend Mr. Klein the courtesy to be able to verify these dates and make sure that they are the correct dates. Okay.
And
And do we Zoom with ATI coaches? No, you won't Zoom with them. Everything that you do will be via email.
so they do
Okay.
everything on their own.
Yeah.
Yeah, okay.
Okay.
I have a question. I'm a little bit confused. So the modules where we get the 15 points for in class, is that
Yes.
what you're talking about, that we will get an email in order to access it? Because I went into ATI and I can't find anything like that right now.
I know you can, and that's really good, Heidi, that you were looking and seeing if it's there. It's not going to open it. It's not going to open to you on your ATI.
ATI?
I'm just trying to think right at this moment. It will open on your ATI account.
That's why I'm
So
wondering if there's like a code for us. If we have a certain code, because that's what we used to do previously. We would type in, we would add product and we would put in the
Right.
code number. And then that's how we were able to access things through ATI.
yeah,
But-
and it's not going to work like that. It's not going to work like that. It's not visible right now because ATI hasn't opened it to you.
Okay.
So roundabout, once you get that email from your coach, and then you go on ATI, and the email will probably have additional instructions for you. Then you go on to ATI, and then the virtual campus will be open and available to you.
Okay, so my next question is, how is the point system, how does that work? Do you get a point just for completing that module, or how is the points distributed?
Yes, and that's a good question, Heidi. Like I said, these modules are going to have a series of things for you to do. The first thing, and I'll use fundamentals because that'll be module number 3. First thing is your ATI coach is going to tell you to take this diagnostic test. That way they can see, where your strengths are and where your weaknesses are. And then your coach is going to build a remediation program for you to strengthen your weaknesses. Once you complete that remediation program, and there might be, again, we don't take these modules. I can just tell you what I see on the report, but then there's going to be sort of an ending grade that you're going to get at the end of those modules. But the most important thing is that your coach is going to tell you, you have successfully completed this module. Please move on to the next module. And that's the report that I get. So now I know that you've successfully completed module 3. I go and I give you 5 points for that.
Okay, that's what I was wondering. So
Yeah.
the points are given upon completion of the module. All
Yes,
right, okay.
exactly.
Thank
And just in my experience on the Gettysburg campus, where my students run into problems, are right there. Usually pharmacology tends to be a tough one. Anybody here going to say, yeah, I love pharmacology, and I'm like absolutely brilliant in pharmacology? No, that tends to be a really tough one to get through. So they spend a lot of time in pharmacology, and then all of a sudden their time management skills, they're getting towards the end of the mini-mester, and they haven't even opened module 5, which is med surge. So I'm constantly, come on, you need to get this done. We've got, you've only got so many more days left, or that sort of thing, which I'm sure Mr. Klein's going to do. I'll insist that he do that he rides you guys pretty tightly and say, come on, you can get it done. Your coaches are going to be saying, come on, you got to get this done. But anyway, if you get to that point when grades are due, when we actually literally have to enter them in to the registrar's office, and you haven't finished, then the number of points, you don't get credit for any remaining points. And you'll get an incomplete. And that's what we don't want, because then that jams you up at the state board site. And we don't want that to happen to you guys. So if we get a little ugly about this, we're doing it, to benefit you. We want you moving forward. We want you to finish the program. We want you to get out there, pass NCLEX, be successful, and get your jobs. Okay.
All right. Oh, Dr. LaRue, question about the comp predictor. So you can gain up to 4 points, but that's not based on the score that you received on the comp predictor. It's based on the probability of passing score.
That's exactly right. And that's where, Christina, I don't want people getting really nervous. And when we go to take the comp predictor, it'll be like any other proctored predictor test that you've taken, where as soon as you submit it, you're going to get a score back. You have to take that score and then translate it over to the probability of passing NCLEX. So then the points that you're awarded, and we've got a scale for that, are based on what those probability scores are.
Okay. All right.
Okay. All right.
What
Oh,
questions, what questions do the students have about ATI and virtual ATI? Because now's the chance to get it clarified.
I don't know if I missed this, or if it will open up later. The RN Leadership Online Practice 2019A, is that going to open at some point?
I will make every effort to get that open for you today.
Okay. Thank you. Sorry.
I will tell you, and I've run into this on my campus, where some of these assessments have not been loading. And it's a very quick email to ATI. Hey, cohort 1021 stack at Harrisburg campus does not have the leadership module. Get it on there. As soon as it's on there, I'll make sure it's open for you guys. Okay.
Thank you.
All right. Can I get some smiles? I want smiles instead of tears. Oh my gosh, guys, this is like, the brass ring is right there. You can see it and you've almost got it, okay? We'll get through it. And you know what? I think in the chat room, and I know that Mr. Klein is, again, just can't say enough how wonderful it is that let me just do this. That he was able on, the turn of a dime to step in. But I'm gonna type in my name, how to get in touch with me. Those that had me over the summer, I get back to you as quickly as I can. And anything that I can do to give you guys a hand. I mean, you've come this far, and buddy, we're not gonna let you down at this point. Okay, our goal is to get you to the finish line. All right. So it's an all hands on deck effort. And you also got Mrs. Reardon too. All right. So if you need anything, you just let me know. You got yourselves a good guy over here, okay?
Yeah, I'm in
All right.
that for 8 years, and my clinical students have always loved it. So yeah, we just got off to a bad start with this course.
Well, you know what? Sometimes, it is funny, the organization of it. I always love the first week of class, because I'll tell you, there's nothing like student eyes that can just, get into those nooks and crannies and go, wait a minute. So, we're still within that first week, guys. Good for you. Thanks for being, sharp-eyed. That's what we want in nurses. So, give us the opportunity. Point it out. Oh, Brooke, how are you? Good to see you, buddy.
Good to see you too.
Anyway, we'll get this documentation squared away for you and get it out to you. Please do not hesitate. Don't sit, don't, go, oh my gosh, they don't know what they're doing. Just communicate with us and we'll get answers to you, okay?
Yeah, and I've apologized to him because I told him it was going to be you or Mrs. Reardon here this morning. Now it's 1:30 in the afternoon to go through the ATI stuff, which I knew was a mess, and no one showed up earlier. So that set off the whole powder keg of anxiety and a lot of problems. So what we've been doing, getting through the content, Mr. Leib's content, which is the med-surg critical care stuff. And I'm going to have to podcast Mrs. Reardon stuff, which is not everybody in this group is LPN, but I think by now most everybody has common knowledge as far as what you got to do the licensing process and what that means, and interviewing, because I think you've had to have an interview somewhere along the line by this time as an adult, so you should have some understanding of common things to interview. So I think that material is not that complex that I can podcast it.
Yeah. And you know what, Mr. Klein, how about if you and I do apologize, I was under sort of a different assumption. Let's get together because we want to be able to kind of present. I do know, these are nurses that that are in your class right now. So they've been through this already, but, we do want to make sure that we go through interacting with the State Board of Nursing, so that there aren't any glitches.
Okay.
As they up their license from LPN to RN, okay?
Yeah. Yeah, we're just, we're in a time crunch because, and you might not understand, the content I have to present was designed to be given over 2 days, not one.
Ooh.
Yeah, so that's the problem. Yeah.
Okay.
So that's why I'm saying I think some of this could be podcasted because most of Mr. Leib's content is podcasted anyway.
All right.
I'm only doing a small quarter of it.
Okay.
Yeah. So.
All right. Well, listen, it was so nice to see so many wonderful, familiar faces. You guys just keep smiling. Just hang in there. We'll get it done. Okay. And with smiles on. All right.
Question. Sorry.
No, that's okay.
So the 15 points we get for the virtual ATI are also built into our curriculum. Those are points we'll get for the class also.
It certainly is.
Okay.
I like to think of those as the free points, just do it and you get the points. All right.
Sounds good to
All
me.
right. Okay. Any other questions? All righty, guys. Hey, I might zoom in with you later. Okay.
Yeah, that's good.
See you. Thank you so much, Mr. Klein.
Hey, thank you for coming in.
All righty. We'll see ya.
Yeah, have a good afternoon. All right. We are down an hour and a half. So let me get through at least Mr. Leib's content. So you have like the most complex stuff reviewed. I'm probably gonna have to come to podcast Mrs. Reardon's stuff because I think that material you can figure out on your own because a lot of it's common sense and the information that gets into NCLEX, it's a little bit more complex, but it's well explained by their PowerPoints. So what I can do is podcast that. And then if you want me to just go take a couple minutes next week and go through sections, if that works best. Because I want to make sure you get the med-surg critical care stuff. To me, that's more pertinent than how to interview, because I think by now you all have an idea that you show up dressed accordingly and your resume is perfect. There's no errors. You're going to go in prepared as far as questions for the interviewer, prepared to answer their questions, because I can tell you interviewing with HACC, even Frederick, I was given an opportunity to work at Frederick Community. I could have gone there before going to HACC. Very similar. So if you go online and you just type in graduate nurse, RN interview questions, you're going to get hundreds of questions. And many of those are going to be the real ones. And I found that out with faculty interviews. A lot of the questions are the same. So I practice and practice, and obviously it worked. So it's that sort of thing. And I think everybody's smart enough here to know what to do with the interviews, but with the content getting into NCLEX, I'll podcast that too. If you have questions, we'll just hit on it next week. I just don't want to get behind with content lecture material, because if we get behind, we won't get caught up, because everything goes twice as fast for your particular section in the weekend students in October through December, because it goes twice as fast. And I just don't want to mess up hitting important content. That's all. Any quick questions about anything else, not ATI?
No, but were you going to show us quick one where your ABG paper is on the content
Absolutely.
page?
Let me make sure I share screen here. Can you see, can everybody see the course shell? It says Mr. Leib's content at the top.
Yes.
Yep.
So you want to go to anything that's kind of med surge, critical care. It's going to be a Mr. Leib section. Anything that's management leadership. So all the resume, interviewing, NCLEX review, question writing. That's all going to be under Mrs. Reardon's stuff at the bottom. So I'm going to go back to week 1, Mr. Leib's content. So if you go to need to know, and again, anything under need to know, you need to know. So you definitely want to make sure that you look at everything that's under need to know. If you need additional explanation, I would go under the section that says tools to assist your learning. So I'm going to click in need to know. So we're going to go to that subsection. So what I'm doing with you today is Mr. Leib's copy of respiratory case study. And what I want to do is open that up so you guys can see that. So Mr. Leib's copy of respiratory case study, this is the PowerPoint I'm showing you today. So you'll be able to get the answers to all the ABG questions, because that's good to know. At the very bottom, it goes through lecture podcasts. So Mr. Leib has podcasted all the information about mechanical ventilation, gives you more detail on that, respiratory failure, more on ABGs. At the very bottom is review of ABGs and respiratory shunting. This is my handout. I'm going to download it because the images are high res, and high res doesn't show up well in D2L. This is the actual thing. Can you see this okay?
You gotta fix how your screen's sharing.
Oh, really? Okay. Let me show you. Go back. If while we're on Zoom, if you can get into the show and download it, that may be a better thing to do. What I can show you, kind of show you the camera looks like. It should be this blue chart. And I think on camera it comes out reverse. But what this does is it has all the different compensated, uncompensated, partial, and then lists metabolic and respiratory alkalosis, acidosis. It's really good chart to review for this first exam. And then at the bottom is a handwritten chart of how shunting works. The whole shunting diagram is this further explanation of what shunting is. And that's in one of the video links that Mr. Leib has as part of that whole list of podcasts. It's down in there. I just drew it out for better review because I'm more visual than auditory. So
Thank you so much.
Is that better?
Mhm.
Can you see that handout? Okay.
I can't see it on there, but I actually printed it out real quick while we were talking. So, and it
Good.
printed out pretty well.
That's
Yeah.
probably the best thing to do. I think because
Yeah.
it's the images are high res. I had to do high res for it to be clear when you print it out. Or if you look at it in your computer, a lot of these, it's gonna be hard to look at it on a phone. So really try to get on a computer to look at it. This chart at the top is gonna save you, it's gonna help you a lot with what I'm reviewing today with ABGs. The bottom shunting thing, that's a visual of what the video link is with the physician that Mr. Lieb has is one of the links in your podcast section for need to know. So that's all that is, that this replicates. And I want to get to that before we finish at 3 to help you. Any other questions? I'll get back to the PowerPoint. We'll finish out Mr. Phillips here, get into a couple other things with respiratory failure, and then get in mechanical ventilation a little bit. Can everybody see the PowerPoint screen okay?
Yeah.
Good.
Yes.
Okay. So we left off, went through a lot of ABGs. Main thing with ABGs is keep reviewing them. They're like EKGs. You just got to keep studying it to get the concepts down. And just keep in mind, you want to know in my chart that I pointed out where it is in D2L, print that out, study that, and you'll be good. Just keep practicing the tic-tac-toe game. And again, the answers, the tic-tac-toe game itself, I think it's very confusing. I'm not going to use it again. Just understand, looking at the particular components of ABGs, knowing that combination of high, low between the 3 components, pH, CO2, bicarb. If you know the combination of those, how that works, you'll get it. This takes a little bit of time to review. Back to Mr. Phillips' situation. We know what his ABGs were. Now we're looking at his chest x-ray. So his chest x-ray shows pneumonia to the right middle lobe. He has atelectasis in the bases. So we're going to increase his oxygen to keep his sat greater than 90%. And with COPD patients, and sometimes you have to do this, you got to give them not just cannula, but mask. You know, it's against what you're taught, but sometimes you just have to do that to force oxygen down in their lungs because something is happening where they're not getting oxygenated, which we're going to get to. And no, that goes against what you're taught, but sometimes you have to do this. And I've done it in EMS. I've done it as a nursing home, hooking up 2-3 concentrators to get it to work until EMS came and got into the hospital. Bronchodilators, maybe it's going to be a nebulizer for sure because the inhalers aren't going to be enough. This X-ray is just showing the pneumonia and the atelectasis. I just point out to students that usually the right side of the screen, the right lung is clear. That's what we should see. But if there's any cloudy, opaque areas, that's where fluid is usually accumulating. I don't get any more in depth than that because nurses normally do not interpret radiology tests, x-rays, ultrasound, MRIs, CTs. That's not our role. That's for physicians to do. Treatments with oxygenation issues in general. We're going to apply oxygen. Remember, oxygen is a drug. It can become toxic. For adults, that's usually not an issue with short-term use. It is with kids. You have to be careful with oxygenating kids and neonates, but we're all focused on adults in this course. There's the simple face mask with the cannula. There's the normal breather mask, which is the mask with the bag. You have to fill the lower reservoir bag a third of the way with oxygen, so that properly works because it pulls, the non-breather mask pulls from the bag and from the room air to create enough force to get the oxygen into the patient's airways. And then vapotherm, which is high flow, that's what's pictured at the top of the screen. And what it does is it's a higher flow, so it's higher velocity of oxygen. It's a higher rate of liters to force the oxygen deep down into lung tissue. Steck Medical uses it frequently. My mother got it when she was in her final days of life. It is moisturized. There's always like an IV, it looks like an IV bag of fluid to hydrate it so we don't dry out the airways fast, because the problem with vapotherm or high flow, because you're giving high flow oxygen through it. And RT would set this up. I don't go into detail with it because you would get this in a critical care course. You just got to know the basic concept of it. Because of the velocity and the high volume percentage, it dries out airways really quickly. So there's always a bag of saline that's connected to it. And RT sets this up with a special cannula mask for the patient to use. It's just there to further push the oxygen into the lungs. Positioning of comfort, continuing to monitor the ABGs and correct them. We'll use BiPAP, and our last resort is intubation with mechanical ventilation if necessary. Medications would be the vasodilators, the steroids. Bumex is a very good one. Sometimes we use that as an IV infusion. Antibiotics is ABX. Diuretics would be the Bumex. Steroids would be, and I said that incorrectly, steroids would be your Decadron, dexamethasone. Blood products sometimes if they're anemic, and analoxylix. So what's going on with Mr. Phillips here? He is an acute respiratory failure with chronic respiratory failure. So he has his emphysema, his COPD is continuing, but he's also in an acute respiratory failure state. So normally, and there's another video here, which you can watch on your own. Normally, this is how oxygen is supposed to be exchanged between the bloodstream and the alveolus. There's a pulmonary artery and the pulmonary vein. The pulmonary artery is bringing in deoxygenated blood. Our alveolus is passing oxygen into the circulatory system here where the pulmonary artery and pulmonary vein connect. Those vessels are returning back to the alveolus CO2, so we blow out the CO2. But when we inhale, we're bringing in oxygen. We're passing the oxygen from the alveolus to our bloodstream. So then the oxygenated blood goes out to the pulmonary vein to the rest of the body. That's how our normal life-sustaining oxygenation should occur. But in chronic respiratory failure, that doesn't happen. So what's happening with Mr. Phillips is there's a gas exchange issue. There's sometimes an absence of acute symptoms. With chronic respiratory failure, there's always chronic low pH. They're always a little acidic as far as ABGs. Over time, the COPD patients do develop a tolerance to being hypoxemic and very short of breath as far as they have a high respiratory rate. However, they can still go into acute periods of respiratory failure, which we call exacerbations. So the obvious one is COPD and neuromuscular disease. And one of particular interest is Duchenne's muscular dystrophy. My HACC students about 3 years ago took care of a guy. He was 27 years old. He looked like a teenager because he didn't fully develop. I don't know if he's still living, but he was at the end stage of Duchenne's muscular dystrophy, which is one of the common 40 muscular diseases. And basically, they suffocate is what happens with them because the muscles atrophy so bad that it starts with their skeletal muscles, then it works its way to the smooth muscles. So the smooth muscles in the lung tissue are the last to atrophy and they suffocate. It's a horrific disease, no cure, although MDA has tried for many decades to find a cure. They get close, but never completely successful. Usually these children, they're usually children, they're usually males, don't make it into teenage years, but this guy made it into adulthood. But yeah, he was at Select Specialty on event, trach, so he was able to communicate with us. He was actually on Facebook, but other than COPD, it would be neuromuscular disease that you would see respiratory failure with. What's happening with acute respiratory failure is that the exchange of oxygen for carbon dioxide is not keeping up with the need of oxygen and the getting rid of the CO2. The acute respiratory failure situation is not a disease, but it's a condition because it comes and goes. It is a situation where the patient can't ventilate and or oxygenate enough to sustain homeostasis. They're just not getting enough ventilation and oxygenation at the same time. So this brings up the hypoxemic situation and the hypercapnic situation. So there's two types of acute respiratory failure. And again, it's a condition. It's not a disease process. There's oxygenation failure is type 1. And then the second type of respiratory failure is ventilatory failure. So oxygenation type 1 is inadequate supply of oxygen in the arterial blood. And type 2, ventilatory failure, is ineffective elimination of CO2. So they're either getting oxygen, but it's inadequate, or their respiratory system's in a situation where it cannot blow off CO2. And we can see that with our ABG readings, as the slide shows. So which type of acute respiratory failure is Mr. Phillips experiencing? Anybody have an idea?
Would it
Type
be
1?
acute on chronic?
Yeah, it's both. He's both because he's both hypoxemic, which means he has low oxygen, and he's hypercapnic, so he's breathing very fast. So he's acidic because he's not being able to blow off the oxygen, but he's breathing very fast to bring in more oxygen, which is not getting totally used properly. So he's bringing in oxygen. Oxygen is getting into his body, but some of it's lost. Some of it's going to a place in his body where it's not being used. That's what's going on. He's both. So what is the cause of the acute oxygenation failure? And it's the pneumonia that's going on. Now we saw what the chest X-ray. So looking at kind of related to nursing diagnosis, there's an alteration of gas exchange. Perfusion might be compromised. There's pulmonary capillary bed dysfunction. There's an inability of the body to get oxygen to the alveoli. So there's something going on to prevent oxygen to get there. And this is where the concept of shunting comes in that I drew out on that handout with the ABG chart. As a result, he's not getting the oxygen that he needs. So the concept of shunting, there's perfusion without ventilation of the alveoli. There's dead space where there's ventilation without perfusion of the alveoli. And as a result, what we measure with an O2 Sept monitor on a nail bed would be low concentration of oxygen. So the pneumonia, the pulmonary edema is causing shunting. And as you listen to Mr. Lieb's podcast, he's going to talk about ARDS, acute respiratory distress syndrome. That's another way that shunting can occur. I will say I saw shunting with my mother when she was actively dying, and I saw shunting with my wife when she was in ICU because of COVID. Fortunately, she did not need ventilated, but she was working towards that because she was in pulmonary edema from getting too much IV fluid. So I've seen this in real life, and you're giving 100% oxygen, but your O2 sats and your ABGs are showing that the patient's not getting oxygenated, and it's shunting, which I'll go through. With dead spacing, hypovolemic shock can cause it, as well as PE, because the dead space, if there's a pulmonary embolism, a PE, it's blocking the allowance of perfusion. So there's ventilation, there's oxygen entering, but something's blocking it to get to the alveoli, and that would be like a PE. As this diagram shows, you get a pulmonary embolus in the lung. It's acting like a stopper or plug or a cork in an area where it's not allowing perfusion of oxygen to the alveoli, so it creates dead space. My diagram is a little bit better than this, but basically the shunt involves an alveolus, pulmonary capillary, and what happens is the alveolus is being ventilated, but the exchange of oxygen doesn't occur, is what's happening in the shunt. And pulmonary edema is one reason, ARDS is another, pneumonia could be too, as in the case of our patient. But what happens, particularly in ARDS, which you'll review with the podcast, ARDS is severe respiratory distress. If we don't address somebody's shortness of breath, they can go into ARDS. It's usually ARDS comes from severe pneumonia, COVID, infection, and trauma. So the body tries to do something to compensate, correct the issue of shortness of breath, but what it does is causes each alveolus to fill up with this protein fluid, which looks like pus, and it gets trapped in each alveolus. So instead of having oxygen in each alveolus, you have this high protein fluid buildup, which looks like pus, and it doesn't allow the oxygen to get through the whole alveolus, so you have the shunting going on. So some of the oxygen that the patient breathes in does get utilized, but then some of it gets shunted. It gets stuck in the alveoli. This is another concept that you're going to have to review. In my diagram, which is also part of the handout with the blue chart for ABGs, explains the shunt. And basically, you have the pulmonary artery on the left, pulmonary vein on the right. The lungs are providing oxygen, and it kind of breaks into two flow situations. So you have blood coming from the pulmonary artery at the top, and it's going over, picking up oxygen from the lungs. It's going into pulmonary vein. and it's fine. But at the same time, there's oxygen that's also going somewhere else in the body, and it's trying to pick up oxygen. It gets very little because it's getting lost. It's getting pulled away from where it should be in circulation. The oxygen is trying to get into the alveoli, and it doesn't completely. And therefore, the patient's oxygen is being shunted. The pulmonary edema and ARDS are examples of how shunting occurs. And what I can do here, let's grab my models. Can everybody see the cup of blue water? This is a normal alveolus. Our alveoli should look like this. Should have blue oxygen, or basically, I'm using blue to illustrate oxygen. So our alveoli, the thousands of them that we have in each lung lobe, should be full of oxygen. So that's the blue water. What happens in shunting is the oxygen is trying to enter the alveolus but gets stuck. So it just kind of sits at the top of fluid that's stuck in each alveolus. And I'm using corn syrup here because it's thicker than water. So what happens in shunting is oxygen is trying to penetrate or make its way through a whole alveolus, but it can't because there's something going on there. Either PE or this high protein fluids in the way. This cup of corn syrup with the blue dye is oxygen. The oxygen is not making its way through the corn syrup, which is the high protein fluid leaking in each alveolus. This is shunting. This is ARDS. And this is also how COVID patients do not survive. That's how they suffocate, because their alveoli fill with this high protein fluid, which is also ARDS. So with ARDS, you have not just the acute respiratory distress syndrome going on, and it occurs in 3 different phases that you'll learn through the podcast. But also what's happening is shunting. So patient's getting some oxygen, it's going out and being utilized in the body, but some of it's also getting sent to the lungs where it's getting stuck, where the oxygen is not being used because there's some issue going on with the alveoli. And with ARDS, it's this thick protein fluid that starts to fill into the alveoli, and the oxygen can't push through it and get stuck. What we do with ARDS, when there's severe ARDS situation, they're on a vent, they get medicated medical gas with her oxygen and air that goes through the vent. To the medicated gas that you'll learn about pushes the oxygen further through. And we try to oxygenate the patient that way. So we're trying to overcome this thick accumulation of fluid in their alveoli by pushing the oxygen into their lungs with this medicated gas. And you'll learn about that through the podcast. It's not a significant thing to know at this point, but just know the basic concept of shunting in dead space. I just show the cups of fluid because for many students, it helps them further understand what that means. Dead spaces I reviewed, that happens with like PE. The volume of air that's inhaled does not take part in the gas exchange. So the body's trying to exchange gas, oxygen, and CO2 between the bloodstream and the lungs. It doesn't happen. It does not occur because there's something blocking it. and that'd be like a PE, pulmonary embolism, is blocking the exchange of carbon dioxide and oxygen. And as a result, there's dead space and the patient can't be oxygenated. And as a result, they can't breathe. So why is Mr. Phillips having ventilatory failure? And that is COPD, his emphysema combined with his worsening respiratory fatigue. If you ever get extremely short of breath, as I know from my wife, is extremely fatiguing. It does not take but several minutes to get to the point where you can no longer breathe. And it depends how sick the person is with other issues. So this man, he's developed a tolerance to being short of breath. He's short of breath all the time, but he's developed pneumonia, which has made it even more difficult. And the pneumonia has made his effort to breathe even more difficult. And as a result, the pneumonia infection also increases the symptoms of COPD. So that's why he's starting to fatigue. It's taking him so much more effort to breathe. With ventilatory failure type 2, the problem is getting CO2 out of the lungs. And again, ventilation involves the movement of air in and out of the lungs. And this is your minute volume. And this is going to come up again when we look at the ventilator stuff. And this is the calculation. And at this point, this is more of an awareness. You're not going to have to do the calculation on our exams now. If you work in critical care, you'll get much more instruction and you'll have to do the calculations to be a critical care nurse or definitely certified. But when we look at minute volume, it's all related to ventilation. Normal is 6 to 10 liters a minute. And this is something that you'll see with vent settings. In hypercapnia, the increased respiratory effort develops as minute volume and decreases to 4 to 6 liters per minute. Again, I think once you listen to the podcast, this will make a lot more sense. The ventilatory failure, getting air and oxygen in and out of the body, not just COPD and pneumonia, PE, ARDS. It's also related to mechanical abnormality, which would be chest trauma. So in this picture, there's a victim of violence or accident. Rib fractures, flaval chest. Flaval chest is where you have multiple ribs fractured together. And that section of rib is actually moving separate than the rest of the rib cage. Burns, definitely a part of that issue. And obesity, depends upon how obese the person is. Impaired muscle function, again, muscular dystrophy is a big one. Multiple sclerosis, Guillain-Barré is a part of that as well. Myasthenia gravis is MG. Spinal cord injury, and again, depends upon where on the spinal cord the injury occurs, determines the level of ventilatory failure. And respiratory control center, if there's a stroke, if there's neurotrauma, if someone has trauma to their brain, particularly brainstem, there could be significant ventilatory issues. So strokes, particularly if someone has a brainstem stroke, they could be automatically have to be put on a ventilator to oxygenate them because they're unable to breathe, breathe enough on their own to maintain life, or they're not able to breathe at all. So strokes, as you know, can be minor or significant. So yeah, if someone has a brainstem stroke where it's affecting the breathing center of the brain, that can cause significant ventilatory failure. And then neurotrauma, depending upon if it's neurotrauma, and that probably would be some type of trauma from violence, gunshot combat. I'm trying to think of something trauma related to vehicle accident or industrial accident. That would be kind of unique, but it have to be something involving the brainstem or the brain to cause issues with respiratory effort. Chemical depression, narcotics, sometimes anesthesia can cause ventilatory failure issues. Can happen. Someone gets too much anesthesia or how their body processes the anesthesia. They may require additional mechanical ventilation post-op. So we're going to recheck Mr. Phillips. We've done chest x-ray, ABGs. He's had oxygen. He's had his neb treatment. He's more fatigued. He arouses only when spoken to in a loud voice. So he's really going unconscious. He has circummoral cyanosis. So he's getting cyanosis now to his fingertips and around his mouth. So this is the cyanosis was peripheral. Now it's starting to go central. So where do we go from here? The next thing we could try, we're getting very close to ventilator. You're absolutely right. One thing we try to do before ventilator, and it really, Mr. Lee's really stretching this out. So he's trying to cover a lot of stuff, is BiPAP. So this is bi-level positive air pressure. So what I point out, and I know this from hanging around the respiratory therapist, because it was them that taught me ventilators, is the typical setting, and you don't need to know this, but if you see 10/5, 10 is your inhaled pressure. It's measured in centimeters of water. And then the second pressure is exhaled, and that's 10 as 5. So it's always 10/5 is usually the setting that the respiratory therapy will set up for BiPAP if we're using it for acute care. 10 cms of water pressure for inhalation, 5 for exhalation because it's bi-level. 2 different pressures that the patient's dealing with as far as inspiratory to help remove CO2, and then the lower number, the second number, to keep the alveoli open and improve oxygenation with their breathing. So this is mimicking a ventilator. It's in a way mimicking PEEP, which we'll get to. We're trying to improve their oxygen levels while decreasing CO2 because they can't blow off, they can't get enough CO2 out of their body. They need assistance, and BiPAP is the way to do it. BiPAP is also used by paramedics on ambulances with CHF because they have similar issues. It's really like a box with dials, and you're just dialing 10/5. 10 is the inspiratory pressure, and the second, which makes up BiPAP, the second is your expiratory pressure. That's usually set to 5. There may be other protocols that are followed depending upon the severity of the patient, but typically respiratory therapy will start with 10/5 with BiPAP, and hopefully that's enough to deal with the issue of oxygenation and removing carbon dioxide. This link takes you to the video, so do look at that if you need a review of BiPAP, how it works. So we try BiPAP for an hour. We assess Mr. Phillips, he's still drowsy. Now we got to arouse him by shaking him, but he goes back to sleep again, so he's getting worse. His respiratory rate's down to 20, and we're going to do ABGs again. So, well, some of these ABGs are better, some are worse. We're getting to a point where we need to make decisions for more advanced airway management. So he's declining, he's trying to compensate, but his body's not doing a very good job. He's really retaining CO2. He can't get the carbon dioxide blowed off. So we know that he's shunting. So the oxygen is being administered at 100%. but it's not getting effectively utilized. So it's being sent somewhere else. So it could be pulmonary edema. The pneumonia is part of the reason for sure. The alveoli just are not getting fully filled with oxygen. So we're looking at mechanical ventilation. So what we got to talk to the physician about is our assessments, the ABG results, the oxygenation that we've been doing, how much oxygen the patient's been receiving, our neuro assessment, our lung assessment, and skin assessment. That our physical assessment with the ABGs and how much oxygen we've been giving Mr. Phillips, as well as the results of using the BiPAP intervention, that all needs to be relayed to the physician to decide, do we need to move on to mechanical ventilation, which is the last most effective intervention we can do for him. So when we get to point to prepare for intubation of a patient, we got to have an ambu bag, face mask, or a number breather mask applied to the patient, because we really got to get more oxygen, more force involved as far as getting oxygen to the patient. We've got to have an oxygen source. So hopefully you're in a patient room where you have wall access oxygen, because if you're on an oxygen tank, you're going to lose that oxygen supply in a couple of minutes. We have to have an airway, because we got to make sure the tongue doesn't go back and occlude the airway. The ET tube and tracheal tube for adults is typically 7 to 8.5. Smaller ones would be for kids. Yankauer suction, we need to clear the mouth of suctioning of secretions. So you want to suction as you need. We need our stethoscope to assess lungs before and after intubation, because the problem is when you intubate somebody, we need to assess that we are hearing bilateral lung sounds. Sometimes we have to adjust ET tube so we are properly ventilating both lungs, because it is easy when you intubate somebody to misplace it where only one lung gets inflated. So you have to listen carefully once someone's intubated, ensure they're bilaterally tubed, that you're getting ventilation to both lungs. The ventilator itself would be provided by RT. There are portable vents that we can use if we have to move the patient to ICU, and that's all done by respiratory therapy. And anymore, you're going to probably have a physician, usually it's anesthesiologist, comes to the unit, particularly if you're on a medical unit, med-surg unit, that's going to do this whole thing. They'll sedate the patient and they will do the intubation and then release all that care to RT and us. With intubation, the classical way of doing it is with a laryngoscope. It's a battery operated device. The battery essentially provides light to the blade. There's a Miller and Macintosh, and I only know this from doing EMS. The picture here shows a Macintosh blade that's curved. Miller is more straight. In hospital, what you're going to see is the fiber optic lighted glide scope. So if we have a code situation, emergency situation like Mr. Phillips, it's going to be an anesthesiologist coming up from OR with this glide scope. It's a video camera with fiber optics. It makes intubation so much easier to do versus the old way of using the laryngoscope. You got to have a 10 cc syringe, because that's what inflates the cuff to the tube to create the seal. ET tubes are held in place by ties or a neckband that's white and foam in color. The balloon that you inflate with the 10 cc syringe is creating essentially a stopper, a seal, because if you don't have that balloon on the ET tube, essentially the tube's useless. All the oxygen and air that we're giving the patient is going to flow out around it. So the balloon on the ET tube creates a seal once it's in the patient's airway. We put the patients in a sniffing position to properly intubate. I will tell you, it is very easy to break teeth if you use the traditional laryngoscope. So that's why in the hospitals, and I think some of the EMS systems, particularly the air Lifeline, Stat Medevac, because who they are and their capabilities, they have the glide scopes, they have the video assisted intubation technology, but other ambulance-based EMS may just have the traditional laryngoscope tools to do the intubation. This does take practice, and it's difficult. Depends upon if you got somebody very large that doesn't have much of a neck, and you have to avoid breaking teeth, going between the vocal cords. And once this is in, what you're visualizing is the vocal cords, the tongue at the top, and the cartilage at the bottom, and going in between. In the airway, sometimes this is difficult. You got to use the laryngoscope because that's going to help displace the tongue. It's very easy for that to get in the way, occlude your airway. And the glide scope is made to help dislodge the tongue as well. And we want the tip of the ET tube to be above the carina, like 4 to 5 cm. So this is why after we intubate somebody with an ET tube, that we listen to the lungs bilaterally, at least anteriorly, so we know we have equal inflation of the lungs. Because if you don't, then you have to move the ET tube until you get equal bilateral inflation. Now, in EMS out in the field with a trauma patient, it's a situation where they could be properly intubated, but because of lung collapse or trauma, you may only get one lung inflated. So you do what you can do and to get the patient to the hospital to get a chest tube placed, because as far as I know, at least on the East Coast, paramedics can't do chest tubes, but I think out west in our federal or FEMA trained paramedics, they may be able to do chest tube placement, because I know the military paramedics, the FEMA paramedics are trained at a higher level of skill. They're very much close to physician level as far as what skills they do, but they do very different roles than what our typical paramedics do here on the East Coast. Again, intubation, if you haven't seen it before, you can use the link to look at that. So as a result, Mr. Phillips, because he's not getting ventilated enough, he's withholding too much CO2. He's not getting oxygen into his alveoli sufficiently enough to maintain homeostasis, adequate respiration. We got to put him on a vent, so he needs to go to ICU. And he's in a situation where he has both acute and chronic respiratory failure due to pneumonia. Once he gets there, he's going to get an A-line, and they're going to put it in the left arterial artery. Sometimes it goes into the jugular vein. So the A-line, and you'll see this once you do your ICU rotation for sure. If we need to know, because someone's so unstable, we need to know what their exact blood pressure is at this current time. That's what the A-line does. The arterial line gives you real-time readings of internal blood pressure. However, every 8 hours or per your ICU's policy, we'll still check a manual blood pressure to ensure that the A-line is properly working. And then the ICU nurses will show you through the special electronic monitoring. It's kind of like a computer screen, because the A-lines will create a special waveform, and they have to have a notch in them. As long as the waveform is properly being displayed, we know that's working, because the problem is over a couple of days, these A-lines can malfunction, and it does get to the point where the A-lines need to be changed. So they are very helpful for critical patients, but once patient's stable, or if the A-line's not functioning properly, it will need change. But we always check a manual blood pressure at least every 8 hours when someone has an A-line. And again, the A-line is our point of reference for invasive blood pressure, because as you'll learn with critical care, there's the non-invasive blood pressure, which is our blood pressure cuff, and then there's invasive, and that's what the A-line is. So again, the physicians place the A-line because this patient's so critical. We need to monitor his blood pressure readings very carefully, very closely. So Mr. Phillips now is in the ICU. We're treating his pneumonia with antibiotics, which is ARF, and we're treating his pneumonia that causes acute respiratory failure, which is ARF. We're treating pneumonia with ABX, which is antibiotics, steroids, which is probably going to be Decadron, and breathing treatments, probably a lot of neb treatments. If he's intubated, we can still do breathing treatments. As you'll see in ICU clinical, near the ET tube where it connects to the tubing to the ventilator, there's like caps that you can open, pop off. There you can connect a neb treatment or a inhaler. For the most part, it's going to be neb treatments because the inhalers don't have enough force to make it into the ventilator. So you'll see respiratory therapy come. Sometimes they have to use an air pump, a special device to assist with the neb treatments, but you can do a breathing treatment for a vent. It's this additional technology equipment that you got to use. And that's more of an RT specialty thing. And as we eliminate the pneumonia, he should recover fine, and we can cut back on the treatment as far as steroids and treatments regarding his emphysema, get him back to using his inhalers that he's using at home, and then get him off the vent, which we'll get into here shortly, because initially we place patients on the vent to get them stabilized, and then we go through a process of weaning, so where they can go back to breathing on their own. Are you guys feeling any better? Are you guys still very lost, or?
I think that it's just a lot everybody's overwhelmed because it's a lot of content until we understand what all we need to understand for the exams.
I'll give you a blueprint, don't worry.
Okay.
Because when I looked at this 2 weeks ago, I'm like, I got to do 6 PowerPoints in 5 hours.
Yeah.
And today was a big issue because of I knew orientation was going to take a while because you have 2 brand new clinical instructors who are not sure how to do clinical. And I know they're looking to me to help them, which is fine because I've done clinical enough to know what to do. So I'm not worried about it, but I got to guide them. But yeah, looking at this course specifically, it's like, oh my gosh. But yeah, you're going through today would have been 2 separate days. At this point, we've got almost first day done. So that's why
I think that like when we go into, I'm sorry, but when like we go into D2L, there's like 200 and some things listed.
Oh yeah.
6 weeks, and we have to do the ATI assignment, with the ATI assignment and things yet too. And I think everybody just maybe they feel the same way I do. It's very overwhelming. And then you open it up and you don't know, oh no, what are we doing?
Yeah. Oh yeah.
I think that honestly, I think it's always like this. Every semester, the first day of every semester is always very like overwhelming, and we get all the information at once, and it just kind of is a lot all in one day. But I think that as we get going, we always, figure it out and make it work. So don't stress about it too much. We always make it work.
I'm kind of concerned.
will.
I'm kind of wondering how the questions for Mrs. Reardon's will come up on the test. That's what, how do you study for something like that?
The
But we'll figure it out.
PowerPoints will guide you well. They're not that hard compared to what I just went through. I'll give you guidance with it.
Are you
I've
making up the
taken-
exam? Are you making up the exam so it can be a little bit easier?
I have the exams. I looked at them. Believe me, I'm making sure you're getting the content that you need. Oh yeah.
Thank you.
Oh yeah. Yeah, you're getting what you need. And if you study PowerPoints well, you go through the podcasts, you'll know what you need to know. Yeah, and Mrs. Reardon stuff it's not that complex. I mean, I think the interviewing stuff you can figure that out. The licensing, because most of your LPNs, even those that are not LPNs, because we do have students in your group now, it's on Zoom here, that are not LPNs. I'm very certain after you review the course material, you'll understand what the licensing process is. It's very close to having a driver's license, you know. You got to take a class, you got to do the testing, the driver's test, the written test to have a license, and how you keep your driver's license. How can you lose it? Same thing with nursing licenses. Even the nursing license is a little bit more complex, but same concept, you know. But yeah, don't worry, I'll give you plenty of direction with it. The tests will just be worth more points. But there's 2 regular tests and a final to get to the 150. So, and again, the discussion questions, which I know you'll participate more as we go forward. Today is just super overwhelming. Those will be easy to get. What I want to do in this last half hour is get through as much of the ventilator stuff as I can. And then my plan is I want to podcast Mrs. Reardon stuff. And then if you can listen to that, and then next week you can ask me questions about it. If there is any sections that are totally confusing, which shouldn't be, we can review some of in class. I think of anything with Mrs. Reardon's stuff is going to be the new generation, next generation NCLEX questioning, because we as faculty, we have to do it as groups, because we're going to start using it next year. So there'll be more of that in this type of course, but you'll be graduated by then. Making money as RNs instead of PNs. So learning those type of questions is tricky. So that may be a little difficult, but again, if you review it and know the concept, you'll be fine. It really isn't that difficult. I think what we just went through is a little complex. So let me go to. Can anybody see this PowerPoint okay?
Yes.
Okay. So this is mechanical ventilation. And again, vents take a while to learn. Unless you're using them all the time, they're really foreign. At least they work for me till you really start interacting and seeing them in use, then you truly understand it. So we ventilate a patient with a machine when they can't maintain an acceptable life-sustaining saturation of oxygen, and particularly the partial pressure of oxygen, how well oxygen can move from the lungs to the blood. Because our Mr. Phillips, he was getting 100% oxygen, but it wasn't getting moved well from the lungs to his bloodstream because it was getting shunted because of his pneumonia on top of his COPD. So we also ventilate patients because they can't maintain the partial pressure of oxygen. They can't continue to get oxygen from their lungs to their bloodstream. The patient's extremely fatigued with the work of breathing. That was our Mr. Phillips too. They're not breathing at all. So someone that's in comatose state from heroin, is you're going to have these patients. I do know from doing ICU clinical in the area, Harrisburg, West Shore, our patients were either heroin overdose, a few related to other diseases, or they were end of life because their body systems just were shutting down. So it was the extremes. That's what I saw all the time with students. And like I said, it's because of overdose of illicit drugs can cause the need for mechanical ventilation. And another reason might be just to protect the patient's airway, maybe from post-op. And we got to put them on the vent short term. Ventilators, they do not cure lung disease. They do not complete gas exchange, because you got to rely on the alveoli to capture the oxygen from the bloodstream to finish out respiration. And they do not oxygenate tissue. And ventilators, we can't use them for CPR. I think because most of you probably haven't used a ventilator before. When you use an ambu bag or bag valve mask, you're creating tremendous amount of force. And the way the ventilators work, they can't produce that equal amount of force. And they're always set up in a way that they're timed so many seconds or minutes they're delivering a breath, and you can't replicate that in a code situation. So that's why we always use a bag valve mask, ambu bag, because there's no ventilator that's been created yet that can mimic the function of a ambu bag. So that's why during CPR, we just can't hook the patient up to a ventilator because it doesn't work. What they do is support ventilation. So they move oxygen and air in and out of the patient's lungs. Now, keep in mind that a ventilator gives a patient both oxygen and air. It's not pure oxygen. Patients don't need pure oxygen because we're doing it directly into their lungs, and it's a safety thing. They would cause an explosion. Any spark would cause an explosion and fire because the oxygen is under pressure. So ventilators, that's why you'll see two tubes. One tube is oxygen. The other tube is expiratory oxygen and air that the patient's breathing out by the machine. In the back of the machine, there's a vent, and you'll see it and you'll hear it, and that's where the expired air goes. But there's two hoses connected to the vent to the patient's oxygen and air supply in the room. So the yellow hose or connection would be air, compressed air, and the green would be oxygen. So the vents always give oxygen and air, and the RT staff know how to set that up. So it's a correct blend to give them the right combination of oxygen and air to ventilate them. We do increasing amounts of oxygen with the vent while additional therapy is given if it's required. So we'll give a patient 100% oxygen briefly before and after suctioning them, for example. That's something you'll do in clinical. I'm going to mention here again the non-invasive ways to ventilate a patient. And again, this is just to keep the alveoli open and improve those CO2 oxygen levels without going to invasive procedures with it, which is intubation. What we've already talked about is bi-level positive air pressure. So again, it's common settings 10/5. And we're doing this for COPD, CHF. The patient wears this very tight fitting mask. It's god awful. They feel like their face is being smashed into their neck. And they're constantly getting this blowing air into their face. And this one's bi-level. So again, there's one pressure of air going in and one pressure of air for exhalation. Continuous. is this a constant blast of oxygen and air? And the primary use of CPAP is for sleep apnea. It's just ensuring that their airways are open, they're exchanging CO2 and oxygen correctly while they sleep, because as they sleep, there's something occluding their airway. There's a picture of the mask. It is god awful. A lot of patients complain about it. It's like a plastic, hard plastic box, some people say, but you got to wear this special strap that goes behind the neck. They're all Velcro straps, but it has to be very tight. If there's an air leak, the patient's not getting the correct pressures. They're not getting ventilated correctly. Some of these machines that they're connected to, as far as BiPAP, CPAP, have alarms so you know there's an air leak. The mask may cover both the nose and the mouth, or just the nose. This depends on what is determined best for the patient. With artificial airways, there's cuffed endotracheal tubes and cuffed tracheostomy tubes. So they got to be cuffed. And if we do get into trachs, I know trachs really well, but you have to use cuffed trachs because you got to create a seal. So when you pick up an ET tube or a trach, and there's a balloon on the end like a Foley, that balloon is called the cuff, and that creates a seal when you place it into the airway. If that cuff or balloon wasn't there, the oxygen air would just escape out around it, and we wouldn't be able to ventilate the patient. So intertracheal tubes or ET tubes, they're always cuffed. They always have the balloon. However, there's trachs that don't have cuffs because the patient can breathe on their own, but they need the cuff and they need the trach to maintain their open airway. That's what the difference is. But I think trachs we set for later to review. Main thing here with the ET tube is placement. The little tube that comes off the ET tube with that special clear plastic, dark blue color attachment there. That's where you put a 10 cc syringe to that. That's how you inflate the cuff upon intubation. RT has a gauge, looks like a tire gauge, and they're going to check the pressure of the cuff of the balloon every 8-12 hours, because if the balloon is too inflated, it's going to start breaking down the airway. So you can get like ulcers. It's grotesque in their airway. Or if it's deflated too much, the ET tube is going to come out. Now, we use special ties or foam white restraints that we put the ET tube, we tie the ET tube into to keep the ET tube from coming out of the patient's airway, because all the balloon does is creates a seal so that the patient's adequately ventilated. This is an example of a size 8 trach. And I know it's 8 because the number 8 is on the flange. That's the front piece of the trach. It's a disposable inner cannula, which is in the middle of the photograph. Those you can clean and replace. And the number 8 is also imprinted on that. And the piece of plastic at the bottom is your obturator. If the whole trach should come out, and with new trachs, they are sewn in place with nylon sutures. You'll know because it looks like black fishing line. Basically, that's what it is. If a trach should come out, you stick the obturator directly into the trach and push it into the patient's airway stoma until RT can come back and put in a new one. We will put in a new one, which is sterile when RT can happen, but can get involved. But if you're a nurse and your patient's trach is out of their airway, the obturator we usually tape or place around their head of the bed so it's easy to find to get the airway back in. Because if you don't get a trach back into the stoma open area of the airway, they will close within several minutes if they're brand new. And then that clear piece of plastic with the tiny tube connected, that is your indicator for the cuff on the trach. So if this tiny little bag with the tiny connecting tube, if it's flat, your cuff is flat. So that means it's not inflated, it's going to come out of the patient's airway. The trache's not doing its job. When the indicator bag is fat, it's inflated with air, the cuff or the balloon on the trach will be inflated, and that's what we want. And again, RT is going to check the pressure of this throughout the day and night to ensure that it's not too much pressure or too little pressure. Getting into the ventilator settings, there's the tidal volume, the FiO2, and the rate. Basically, tidal volume, and RT abbreviates this as VT. This is the amount of air the patient receives with each breath. So every ventilator, regardless of how it's set up or what manufacturing style or type it is, always has a tidal volume, FiO2, and a rate. So the ventilators in the hospital, ventilators in a nursing home, the ventilator that's on Lifeline, all have these basic settings. It's this how those settings are combined and used makes them into more of a group of settings, which we call modes of ventilation, which I think we get to later. So the amount of air patient receives with each breath is the tidal volume. And for adults, it's between 400 and 600 milliliters of air, and that's oxygen and air. The FiO2 is its fraction of inspired or air that's been breathed in. And again, FiO2 is somewhere between 21% and 100%. So 21% is the air that we all breathe, being in a room, being outside, being in a car. It's our atmospheric oxygen saturation or concentration of oxygen in the air around us. 100% would be the max amount of oxygen we can give somebody through a vent or some other oxygen device like a mask. We have to warm and humidify oxygen in the air with the vents. Otherwise, we're going to dry out the airways very quickly and will cause damage. And as the secretions occur, because with an airway, artificial airway in the patient's trach, whether it's trach or ET tube, those are foreign and the body's going to automatically cause a lot of secretions to develop. So we can give medication to slow it down. But if they have pneumonia or other issues, there's going to be a lot of copious secretions. So the warmed, humidified oxygen is going to help with getting it out. So you'll learn how to do suctioning of a patient that's on a vent in clinical. That was something we did in the lab with 251 students, enclosed or Ballard suction. We also showed nasotracheal suction or manual suction. We demonstrated that had you practice that in lab, but unfortunately with COVID, we can't do that. Ventilator, as far as ventilator settings and rate, that's the number of breaths delivered per minute. And PEEP. PEEP is doing what BiPAP is doing. So this is positive end expiratory pressure. So this is the amount of pressure that occurs at the end of a breath to keep the alveoli open. PEEP is very important for all ventilator settings, particularly weaning, because what PEEP does, it helps with the effort of breathing. And it's usually 5 to 15. And the key thing with weaning somebody off a vent, getting them off the vent, is we're lowering the PEEP. We're going from 15 to 5. And once the patient's down to a PEEP of 5, they're getting very close to coming off the vent. They don't need it as much. They're able to breathe on their own. So PEEP, keeping those alveoli open at the end of expiration, it improves their partial pressure of oxygen, improves their oxygenation. If they need higher PEEP, can decrease FiO2 needs. Ideally, we want to keep patients' needs for oxygen lower than 50%. So initially, somebody coming out of OR that's on the ventilator, they're going to be at 100% and they're going to get continuous ventilator support. They can't breathe on their own because of anesthesia, or something else was happening with their ability to breathe. So the machine's going to do all their breathing for them. That's fine. But the problem is with that particular mode of ventilation, it can overinflate the lungs and cause pneumothorax. And with that high amount of oxygen, it can lead to toxicity if it goes too many days. So we try not to give oxygen in high amounts to anybody, particularly neonates and kids. But with adults, which is what this course focuses on, with vents, we want to keep oxygen delivery with a vent to less than 50%. But PEEP helps with the process of oxygenating people because it keeps those alveoli open at the end of each breath. Mr. Eve has it as 5 to 8. It can go up to 15 if necessary, but yeah, PEEP pressures less than 5 is therapeutic. So with the weaning process, you'll see PEEP levels down to 5 or less. And once they're down to that, the patient no longer needs the vent. They should be able to breathe very safely on their own. This is this picture of a vent screen. And again, they are not going to be tested on this. This takes some time where you're constantly using vents, reviewing the modes of ventilation. Volume control is a mode of ventilation. It's a particular way of adjusting everything we've talked about so far to deliver oxygen air to somebody to correct a problem or maintain a certain respiratory effort. So volume control is one we can use to provide oxygen air to someone that doesn't spontaneously breathe. And it has a set tidal volume rate in PEEP. So at the bottom, this looks like a Bennett Dixon BD vent. There's Siemens vents. There's some other new models, but again, you don't need to know them unless you're working in ICU. But at the bottom, you can see 21% oxygen concentration, which is room atmospheric oxygen, PEEP of 5, respiratory rate of 20, and you're getting 400 mLs of oxygen air with each breath. So this person's very close coming off the vent because their oxygen concentration from the vent is what all of us normally breathe on our own. If we're inside or outside in the environment, the PEEP is at 5, which is very low, and the respiratory rate is at 20. So that's basically normal respiration rate. And volume of air with each breath is minimal at 400. So this is a good set of vent settings. This person's probably getting to the point where they can come off the vent. Vent alarms, if you work with them long enough, you'll know exactly what they mean. So basically, if you hear one, you definitely want to go and check it out right away. High pressure alarms. These alarms occur because there's something blocking the passage of air and oxygen to the patient with the vent. So usually the main cause is secretions, the patient's biting on the tube, or the patient's coughing. Most of the time it's secretions. Some rare opportunities also are there's too much tidal volume, the patient's biting the vent. If the patient's alert, and patients who are intubated or on a trach, there's going to be a lot of anxiety because you have this tube down your throat, you can't talk. You got to let the machine breathe with you. So it's very difficult to get used to this breathing situation. And besides, they're in ICU, so there's constant someone's touching them. They got a tube in their bladder. They got an NG tube either down their nose or in their mouth, because anybody that's intubated on a vent, you have to put an NG tube in or they're going to vomit. So you have to clear the stomach of its contents constantly with intubation, somebody on a vent. So patients usually in pain, they're always on their back or sides, so they're uncomfortable. Someone's always at them. There's a lot of noise. They can't sleep. So yeah, your patients on a vent are usually very uncomfortable for many different reasons. So you'll see the ICU nurses give Ativan, typically small doses to calm the patients, to stop this fighting the vent, letting the vent breathe with them or for them. Because the more the patient fights the vent, it's going to drive up their blood pressure, their heart rate, which can be detrimental, and it's harder for the vent to do its job. If the lungs are difficult to inflate because they're stiff, they're so diseased that they don't expand well, that may lead to what we call decreased compliance, which increases the pressure alarms. Low pressure alarms is when there's inadequate exhalation of the volume of air that we deliver to them. So typically low pressure alarms is when the ET tube and the vent tubing disconnect, which can happen frequently. And you'll know, when you work with vents enough, you'll know to distinguish the alarms. But basically, if you're a student in ICU, there's no one else around, check on it right away and call for help. But once you learn what the alarms mean and what to do, you'll be fine. Typically, what we do in ICU with students and faculty is, if it's high pressure alarm, first thing we do, make sure everything's connected as far as the vent and the ET tube, and then we suction. Usually that stops the issue. If the patient's really anxious, moving around, trying to mouth words, we let the nurse know. The nurse might have to sedate the patient a little bit. Our team might come in and adjust the vent to make it provide more comforting, easier to breathe settings. If it's low pressure, first thing we do is see if the ET tube and the vent tubing are disconnected, and you put the two back together and everything's fine. The only thing you have to keep in mind, because we're in a time of COVID, you want to make sure you have your N95 mask on and your face shield when you're in an ICU room. It very rarely does an ET tube get displaced or extubated, as the technical term, or does the trach come out if they have a trach. And if an ET tube comes out, it may be because the patient pulled it out, they worked out of the restraints, because usually patients are restrained if they're on a ventilator. Other reasons could be that the cuff hole that's creating the seal for some reason has deflated enough that it allows the ET tube to come out. So if you have no ET tube in a patient, you walk in your ICU patient's room, their ET tube is out, definitely call for help. You can, you're going to have to grab an airway, put into their mouth, into their airway, and then give them artificial breaths with the ambu bag. All that equipment is right beside them. It should be easily attainable, because I can tell you, usually first thing that the ICU nurses do at the beginning of their shift is ensure that they have certain equipment and supplies in their patient rooms. So the ambu bag should be readily available, connected to O2. There should be a separate flow meter for that, and that there's airways to place in a patient. And if the patient's trached, that there's an extra trach nearby, as well as the obturator. A lot of this you're going to get in clinical through just practice or being there. So I don't expect you to know what to do. You'll learn it in clinical or on the job. But as far as the PowerPoint review, what to do with high pressure alarms, what to do with low pressure alarms, what to do if the ET tube comes out. The ambu bag or bag valve mask should always be in the room at all times. Nursing interventions, and I'll get through here quick. We always document the beginning of shifts, like 7 a.m., 7 p.m. Where is the ET tube at, as far as there's going to be numbers and little triangles. You want to measure, document each shift where the line is on the ET tube at the corner of the mouth. This is important so we know that the tube is not coming out of the patient, that they're getting properly ventilated. We check their appearance, their skin color, their nail beds, their vital signs, and their level of consciousness. If they've been alert and oriented, now that they're going a little bit more they seem confused or disoriented or more sleepy, that's a change in condition, something you need to investigate. Suctioning, we used to do this as a skill in 251, but we no longer do. This is closed suctioning or Ballard suctioning. This is the typical device that you'll see in ICU. You'll see this in clinical, and you'll be allowed to do it. The main thing is you see the nurse there has a hand on the end of the suction where you push down on a white piece of plastic to create the suction, and then they hold the other end that's connected to the ET tube, because you got to hold that, otherwise it comes apart. And you advance the tube as you suction, or you advance the tube into the airway, and then you apply suction and pour it out. Your clinical faculty are experts at this. They'll show you exactly what to do and give you much more direction with it. It's hard to do this on Zoom. In classroom, I can show you the actual device, and it makes a whole lot more sense. There is a lot of observation with this. They should cough because you're causing a gag reflex. If they don't, then that's a neurostatus change. That's significant. It's very uncomfortable. So you want to let your alert patients know what you're doing. Even if they're unconscious, you still want to talk to them because it's a dignity thing. They could be still aware of what's going on. You want to observe any suction sputum that you receive and document. You always want to oxygenate 100% before and after. So on the vent, and your faculty will show this in clinical, there is a button to push to oxygenate 100% before we suction and definitely after, because it does take away their breath, and it's very uncomfortable. Mouth care is extremely important. I'm just going to finish this out, and we're right at 3. Policies vary according to facilities. I do know UPMC will use chlorhexidine in addition to like saline or mouthwash to do mouth care. This is very important to decrease the chance of VAP, ventilator assisted or ventilator associated pneumonia. Patients that don't receive consistent mouth care that's effective can develop pneumonia. So that's VAP. It's pneumonia coming from being on a vent. And if this is done every 2 hours, 24 hours a day while the patient's ventilated, we can decrease a lot of the mouth issues that come up and primarily prevent pneumonia. The ET tube will be repositioned as well because the tubes are going to start breaking down the lips, the cheeks, and you may see with some people, and it's god awful, very large mouth ulcers. I mean, they're huge. They look like the size of 2 coins, 2 quarters, 25-cent pieces. So yeah, it can be nasty. So mouth care is super important. Reducing anxiety because of the vents, the noises, again, having all the tubes placed in them. They're very uncomfortable all the time. We want to reassure patients, give them privacy, try to answer their questions. If we have a whiteboard or piece of paper, they can write questions or needs that they have. Allow family to visit as you can. Allow patients and their family to touch one another, engage. And again, all this depends upon hospital policies. We try to utilize sedation carefully because we don't want to oversedate somebody when they don't need to be. But reducing anxiety is extremely important, particularly with the ventilated patients, because they're so confined to bed, particularly if they're alert-oriented on a vent. And having the vent in total control of their ability to breathe is very difficult. The Riker scale, and you'll get this, let me go back to that. The Riker scale, you'll get this in much more detail once you're in clinical. This is utilized to determine the level of sedation and agitation. Nutrition, we have to provide alternate ways of providing nutrition to a patient because they're on the vent, being ventilated, being intubated or trach will cause a patient to vomit. So we will utilize, they can't eat. And even when they're extubated, they can't eat for 24 hours. So we have to do other ways of providing nutrition. So it's going to be IV nutrition, PPN, TPN, or just tube feedings through their NG tube. It's either through the nose or the NG tubes in their mouth, which we call an OG tube. Did you guys want me to stop here and pick up next week?
Yeah.
I think you guys had enough. And I can't imagine why. Oxygenation continues on next week anyway. So what I'll do is I'm going to follow up with Mrs. LaRue with all this ATI stuff. We'll get that corrected. I'll go through the syllabus, correct everything else that's not right. And then I'm going to see what to do about Mrs. Reardon's content, which is a lot easier to review than what we just gone through with all this respiratory stuff. And if I can get podcasts recorded, I will, because I'm not sure how we're going to get through all of that, plus what we got to do next week in one day. So I'll keep you informed by email. Definitely look on the shell under news for updates with everything. Was this afternoon better than this morning? Good. It'll
Yeah.
get better. I think if the ATI stuff was okay, we had a better day.
We understand.
It is what it is. Yeah. I'm just happy that for the most part, I feel in control. I feel good. But I knew the ATI was going to be an issue. And at least Mrs. LaRue got here in time to answer your questions. But yeah, we'll get it all up to speed, corrected, so you have what you need. But yeah, just be aware it technically doesn't start quite yet, and you'll have time to get it done.
Now,
And you'll have information as far as what to study for the first test. So yeah, just relax, just start reviewing everything we went over today. Make sure you listen to the podcasts. And I know the handout that I created for ABGs, that definitely should help you for sure, because it helped me review. So that's why I created it. I found that and it was like the Rosetta Stone. It just answered all the questions with ABGs. And don't get too crazy knowing the detail of shunting. Just understand the basic concept of it. You're not going to have to write out the shunting diagram for an exam. I think physicians do. I don't know of RTs that ever did that, but yeah, I think if you're going to be a pulmonologist, you probably have to draw it out, but not us. Know the concept of how shunting works. Keep emailing me if you have questions. Other than that, I'll see you in another week. Have a good Labor Day weekend.
Thank you.
Thank you. You too. Thank you.
Yeah, take care.